It's my pleasure to be here with you and to share our preliminary experience with the ShearWave elastography in the prostate area. I would like to thank you very much, the Supersonic Imaging Organizing Committee, for their invitation. So as you know, the prostate cancer is still a major issue. That's the second leading cause of cancer death in men and the most common diagnosed malignancy in men. So you should keep in mind these information. And despite the improvement in the diagnostic techniques and in the treatment, there is still a slight increase in the incidence and the annual death rate, while the mortality is remaining stable. The screening is done by annual digital rectal examination and PSA dosage in men after 50 years. And the goal of that screening is to detect the clinically significant prostate cancer in asymptomatic men at the early stage when curative treatment can be used. And all of these words are really critical. So basically, with this screening, it is possible to reduce the number or the average number of metastatic stage. And also, cancer is now discovered at an earlier stage, but there are some controversies about the discovery of non-significant microfocal cancers. And these microfocal cancers, of course, will not necessarily transform to a significant aggressive cancer. In the prostate scanning with ultrasound and MRI, we have the possibility to get the zonal anatomy. And we know that prostate cancer will mainly develop in the external gland, that's the peripheral and central zone, while BPH, a benign prostate hypertrophy, will develop in the transition zone. The PSA, of course, is a critical information for the detection of prostate cancer, and the typical threshold is 4 nanogram per ml, but it's remained discussed right now because cancer can be discovered in men with much lower PSA values. And the other issue is the lack of the specificity of the increase of the PSA. And this is why modified PSA have been developed, like age-specific PSA, PSA density, velocity, as well as the free to total PSA ratio. The potential for transrectal ultrasound at the beginning of the history of scanning prostate cancer was extremely large because ultrasound could be involved in screening cancer, cancer detection, biopsy guidance, staging, therapy, and monitoring treatment response. Unfortunately, due to the lack of sensitivity and specificity, the current role of conventional transrectal ultrasound is mainly the cancer detection in abnormal digital rectal examination or PSA are found. And mainly now the transrectal ultrasound is performed for improving the biopsy and biopsy guidance, as well as brachytherapy when needed. So normal transrectal ultrasound should not delay the systematic biopsy if these digital rectal examination or PSA are found to be abnormal. Contrast-enhanced transrectal ultrasound can be proposed as a new technique and is being under evaluation. And this can be proposed for improving the cancer detection if the normal transrectal ultrasound examination is found, for nodule characterization, biopsy guidance in case of suspicious nodule detected at conventional or contrast-enhanced ultrasound, staging and monitoring the therapeutic response. MRI is the other advanced technique for the detection and staging of prostate cancer. The sensitivity and specificity of each of the MRI sequences are really varying quite much in the literature, and mainly prostate MRI is done for staging cancer right now. However, MRI is a very nice technique with a good sensitivity and negative predictive value when we are dealing with aggressive cancer with a Gleason score above 6 and a nodule of a significant size above 0.3 ml, as you see in these numbers published by in European Radiology in 2009. The sensitivity is about 83%, while the negative predictive value is about 100%. However, the issue with MRI is dealing with cost, availability, tolerance, and also the required imaging transfer to perform the biopsy using the MRI information. So basically, if we're just trying to have an overview of the limits of the techniques for diagnosing prostate cancer, we know that biopsies are critical for the cancer diagnosis and also obtaining the grade of the cancer, but unfortunately, false negatives are found in almost 25% of the cases. Conventional transrectal ultrasound is certainly a useful technique, but almost 30 to 40% of the cancers are not visible. And when you see a very typical nodule in the peripheral zone and you are almost sure that this will be the cancer, unfortunately only 60% of these very suspicious lesions at ultrasound will be true cancers. The positive biopsy rate also depends on the PSA level, but considering all PSA levels, the positive biopsy rate is only 25 to 33 %. So I mean that almost 2/3 of the biopsies will be not positive in these patients. The limits of biopsy also depends on the PSA, and the negative sextant biopsies will be reduced if we increase the number of biopsies, but there's no direct link between the positive predictive value and the number of biopsies. So putting all of these together, we see that there's still some room for improving the diagnosis of prostate cancer. Recent improvement of undercavity ultrasound transducers allowed the use of contrast agents for the assessment of the prostate. And in this case, you see that there's a small hypervascular here, small nodule in the peripheral zone that was considered to be highly suspicious for cancer, and the biopsy confirmed the presence of a small adenocarcinoma, Gleason 6. So this could be of some help, and there are some interesting published data in the literature showing that the targeted biopsy toward these territories is almost increasing by 50% the detection of prostate cancer. So basically, what could be the role for ShearWave elastography? As I told you, there's a large room for improving the prostate imaging for the detection of cancer. The first role could be screening, that means increasing the sensitivity of transrectal ultrasound. The second could be cancer detection and nodule characterization. The third one would be biopsy guidance on suspicious nodule specifically seen at ShearWave elastography, as well as staging, therapy guidance, and monitoring therapeutic response. There are a few tips and tricks for assessing the prostate using the ShearWave elastography. You basically can choose between resolution or penetration setting, and right now we prefer using the penetration setting, but it is very important not to push on the probe, otherwise you will increase the apparent stiffness of the prostate, and this is for sure a very critical point. We reported a series of 21 men, and using state-of-the-art B-mode, contrast-enhanced ultrasound, and MRI techniques for detection of prostate cancer. And all of these men underwent the systematic sextant biopsies and targeted biopsies in case of nodules. And basically, we observed 26 lesions at ultrasound or pathology. Of these, 10 were adenocarcinoma of Gleason above 6. We basically measured the stiffness of the adjacent prostate to the prostate cancer, and you see that there is a very significant difference between the prostate cancer with an average of 55 kilopascal, considering the adjacent peripheral zone around 18 kilopascal. And in case of benign nodules, the result was almost comparable with 19 kilopascal. The stiffness ratio that was very significantly higher for cancer compared to benign nodules, and the cutoff value was 1.5. And you see here on this very limited population the quite good results of ShearWave elastography, but these numbers are really preliminary. Let's see a few examples. Here in a man with a suspicion of prostate cancer, with no cancer detected at biopsy and a normal MRI examination, you see the very nice feature of ShearWave elastography. That's the very homogeneous coding of the peripheral zone compared to the transitional zone. And that's for sure that we're not looking right now for the detection of transitional cancers. We're mainly focusing on peripheral zone cancer. And this gradient of stiffness between the peripheral zone and the central zone is, of course, of a great help. In this man, there was a small nodule, and you see the stiffer appearance of this small cancer. In this man, at the contrary, the cancer was much larger, occupying the lateral peripheral zone on the left side. And you see another case where the peripheral zone here was totally homogeneous, while scanning and sagittal, it was possible to detect the very stiff area corresponding to the prostate cancer. So basically, the semiology using ShearWave elastography is rather simple. And that's one of the first cases that we had, and this man was not exhibiting any prostate nodule, and the peripheral zone was extremely small, extremely reduced. And when we put the box for ShearWave measurements, we found that the entire prostate was extremely stiff. We thought that we were pushing too much, maybe on the prostate, and we being very, very careful, but still the values were extremely heterogeneous and high. And basically of the 14 cores that we took, all of them were positive for cancer, and the Gleason score was 9, so meaning a very aggressive cancer. And the PSA was 4. So basically, you saw that there are limited objectives for transrectal ultrasound with prostate imaging, and this is due to the low positive predictive value for cancer detection. So basically some room open for contrast-enhanced ultrasound and ShearWave elastography. When we're looking at contrast-enhanced ultrasound, this is under evaluation in multicentric trials, and there's a limitation due to the very short time of the arterial enhancement. So maybe we should be moving to 4D capture. When we look into ShearWave elastography, there's for sure large potential, but they need to be investigated for detection, characterization, guiding, and monitoring, because we can also guide prostate biopsy using the ShearWave technique. Thank you very much for your attention.